Right, it's half past.
Okay, you can unmute them. Unmute all of them, yeah? I'm going to be quiet.
I'll say hello.
Okay,
Hello, everyone. Welcome and thank you for coming to our third day of our ISCE Hot Tip series. For those of you who has just turned up for the first time, this is a 5-day series where some of your Cardiff graduates share relaxing talks and help you revise for your ISCEs and get a better chances of getting a better score. So for today's talk, we have two of our very own Cardiff graduates, Dr. Angelica Sharma and Dr. Ruchira Oy. They will be talking about how you make a lasting impression in your ISCEs and nonverbal communication. So I think we have some people still trying to get in. So we'll just give it about 2 minutes before we actually start. Okay, without further ado, I'll pass you guys to Angelica, who will start the station.
Not the station, the talk. We're not in an ISCE.
The talk, absolutely, yes, exactly.
Yeah, hi, I'm one of the F1s. I was in Cardiff last year. I'm going to be talking about how you can make a lasting impression on an ISCE. Not quite sure I'm the right person to be giving this talk, but like the ISCE, I'm going to boss this talk. And yeah, sometimes hard to believe that I'm a doctor, but there we go. Right. So there's this quote that goes around that says, you don't get a second chance to make a good first impression. So I don't like this quote. And essentially, if you mess up, don't panic. And everybody says that to you. And it's literally the most annoying phrase ever. But firstly, the examiner probably didn't even notice. And secondly, literally just carry on. Because if you don't understand one thing, if you say one wrong thing, it doesn't mean that you won't understand the rest of the station. It doesn't mean that you will completely not know the management, because most likely it might be one part that you don't know, but actually you're pretty good on the rest. I'd also say that if you've got to the end, say you've got to like checking pedal edema and you're like, oh my God, I didn't do the blood pressure. That's fine. If you have time and you have realized that you have missed something, either say it or go back and actually perform it. Don't stand back and be like, oh my God, I didn't do this. Now you're sweating. None of this, okay? If you want to make a lasting impression, you go back and you do what you missed off. Okay, so I'm going to reword this quote a little bit, and just remember this as you go through your ISCE. So you might not get a second chance to make a good first impression, but there's always time to make a lasting impression, because at the end of the day, when I'm an SHO next year, I want an F1 who can understand their mistakes, can actually correct them, and can move on. Okay, so remember that quote. Okay, next one. So I'm going to go through each of the domains of the ISCE and give you my hot tips. So clinical examinations, we have gone through this like for the past 6 years, and the one thing that they want you to be is fluent. Fluent means that it doesn't mean that you're a robot, but it means you can anticipate what's coming next. So if you are having a look at the hands, actually look at the hands, because I think sometimes we do the examination and we rush through it and you're like, oh my God, like what am I actually looking for? So go through it systematically, go through it slowly, think about positive features that you can pick up. Now, I know in this ISCE it's slightly different because you may not have pathologies and you're going to probably get actors, but you know, they can have someone with a stoma and just put a photo of the stoma in front of you. They may play sounds of like respiratory or airway noises, but again, this is Cardiff, so maybe not that techy. And good exposure. So clear instructions to the patient during the examination. And often when I've done OSCEs as the actor, I have pretended that I don't know what I'm doing. I've done the opposite thing to what I've been asked. And it's all about how you can make the patient feel comfortable and listen to what you're saying. The next important thing is exposing your patient. Don't do this awkward thing of like trying to put the stethoscope under their shirt. Just be like, and if they say no, that's fine, but actually ask in the beginning, is it okay if we expose the abdomen, or is it okay if we just lift the top up? Okay, don't be awkward. You're a doctor, you need to see the whole abdomen to assess it. Don't be shy. This is all little feedbacks, by the way. So cognizant of patient pain. Now, we always say, look at the patient whenever you're doing anything and ask the patient, where is the pain? Even if they don't have pathology, they can pretend that they have pain somewhere. And the best way is to work away from the pain and then go towards it. But talk through it to them as you're doing it. Just say, you know, does this feel okay? Is this area worse? Is it better? And look at their face. So even in clinical practice, I've got patients who are really hard. They don't want the paracetamol. They're okay. No pain. But when you do press, say they've got epigastric pain, they'll grimace and they're like, yeah, you're in pain. You need that paracetamol. One of the feedbacks I got was, remember to redress the patient. So there I am worrying about what murmur I have and haven't heard. And what the examiner cares about is that I didn't tell this guy to put his top back on. And again, this is kind of simple things that we can all do. This is not diagnosing anything major. It's simple steps. And what they're looking for is a systematic examination. So as much as you can, follow the inspection, palpation, percussion, auscultation. But if you get to the end and you're like, oh my goodness, I didn't do this, you know, I didn't listen to the back, I didn't feel for sacral edema, make it natural. So you could be the doctor that does the feet first and then goes to the back. Okay, don't make a big deal out of it. Other little things, that criticisms that I got was avoid using tendon hammer. So I actually didn't even see the neurotip. I was that flustered. So just to have a good grasp of what is in the room. Remember to do blood pressure, and if you forget, just say it at the end, that's fine. And yeah, just be fluent, but don't be a robot. So talk through everything that you're doing to the patient and make sure that they're on board. That's the most important thing. Cool, moving on. History taking. Right, guys, we've done this since like first year, but please follow the same structure, because either you will go on a tangent or your patient will take you on a tangent. So now I do like acute meds and clerkings. I'll be talking about this patient's abdo pain, like really into it. And the next minute I'll be talking about their pet cat, which is great for social, but bring them back. And the way you do this is like, okay, you know, it's great about your cat, but could you tell me if you're on any medication? Do you have any allergies? As long as you've got that structure, you can guide the patient back, and you can also guide yourself back. Active listening, interesting term. Often in med school, when I took history, I was like, okay, like carry on. Like I need to get to the drug history, past medical history. And by the time I got to that, I was like, okay, I have no idea what you said. What is your history of presenting complaint? Active listening is actually taking in what they're saying and using that to focus your history. So if they're saying abdo pain, okay, you're thinking about bowel, you're thinking about bowel habits, nausea, vomiting, that kind of thing. Just orient yourself to what the patient is telling you and don't dismiss any symptoms. I think in the heat of the moment, they may say something, they may say it kind of passing comment, just pick up on the clues. You know, if they're a bit shy about something that they've said, just pick up on it and just say, you know, is that something that's worrying you? Is that something that you want to talk about? We all know this, open questions, what's brought you in, that kind of thing. But also, it's really important to do that focused history. What have I done? Okay, there we go. But just use that focus history, use that format that we all know. Multiple red flags, let that man, woman, or whoever they are go, but do not let that patient go. Make sure that patient stays. And in the history, this is what you're trying to elicit, red flags. So at the end, whatever you do, just ask about fever, weight loss, bleeding, so hematemesis, hemoptysis, PR bleeding, things like that, just to exclude them. And obviously a bit about visual symptoms. If the history was about abdo pain, just go back and say, you know, any shortness of breath, cough, palpitations, chest pain, just for completeness. And of course, everyone loves doing this, ideas, concerns, expectations, but actually it's quite useful because they may think it's something that you haven't considered and you're like, oh yeah, we could work on that, we could exclude that. And it's also just something, we do it still, so it's just nice to end off. And the last thing is summarizing, which I used to hate because you actually have to do that active listening thing, but it is useful and examiners do really like it. Fine, right, acute stations. Right, so acute stations, I think the word acute makes everyone just rush through it, like, oh my God, emergency. Okay, yes, it's an emergency, but if you rush through it, your diagnosis is going to be incorrect, and therefore your actual pathology is probably not going to be addressed. I would recommend, for the history in the acute station, is to use sample. So you've got your signs and symptoms, allergies, what meds they're on, pertinent past medical history, and oral intake. This is like a nice savvy thing to say because you might be sending off to the surgeons, obviously not going to be performing surgery yourself, but it's useful to know for other specialties. And like kind of what happened just before whatever they've come in with. The thing they're looking for is to be succinct because you want to get to them, to the investigations. You want to start management pretty quickly. And I would use acute stations as a dynamic environment in the sense that if they say, oh, doc, like I'm in pain, I can't talk to you, go away, like it's just too much for me. You can say, right, I can give you some pain relief, and actually say that to them and the examiner as well. So it's dynamic and they'll calm down, hopefully, if you give them the right dose. And actually look at the data in front of you. In acute stations, you're going to be given news charts, x-rays, blood test results, all kinds of things. And you'll just be like, oh my goodness, overwhelmed. Look at each piece of information and just decide in one line, what is it telling you? Is the news score telling you that this patient is potentially septic? Is it telling you that actually the patient's observations are completely normal? Don't then hold the news chart and the blood test and the imaging and be like, oh my God, I have no idea what's going on. Each thing, summarize in the line. In terms of differentials, I think this is the main bit of the acute station because you've seen the patient, you've seen the obs and things. What do you think is going on? Different ways to do this. Top 3, common things are common. So, 1, 2, 3, what is going on? Things to exclude. So maybe there's been a blood test result that's particularly concerning and you're thinking, right, I need to exclude this condition because actually this could be fatal for the patient. And then you go to your niche ones, if time and if you've very aced through the rest, okay? Don't give your niche one first because they will quiz you on it and it's probably something like weird and wonderful that maybe you won't know loads about. Okay, so top 3 and then ones to exclude. The next thing is talk through your thoughts. So why is what you've picked more likely than another thing? Talk through that. Why did you order that blood test? Why have you ordered that particular investigation? In clinical practice, I open ISCE and I tick FBC, CRP, USNEs, LFTs like a robot. But in an ISCE, you have to justify it. So don't order things for no reason. They will ask you why you did it and that will be awkward. So we're avoiding awkward. And like, what are you trying to exclude? Like, what is a chest x-ray going to tell you that you don't already know, kind of thing? I would say just keep calm in an acute one, okay? I know it's an emergency thing, but actually take in what's going on. and not just rush to conclusions like I did, because I got given an X-ray and I was like, okay, it looks a bit like a pneumothorax, and I got given bloods and then the D-dimer was raised and I was like, okay, it's a PE, no wait, it's a pneumothorax, and I just didn't take time to actually understand what was going on. So that would be my spiel for the acute ones. Right, okay, moving on. Data interpretation. Literally don't rush the diagnosis, even if it's super obvious. Don't look at an ECG and be like, okay, this is hyperkalemia. Talking through it makes you look slick because they don't care if you got that ECG in front of you right. They care that any ECG that you will see, you will pick up things. And the way you'll do this is your systematic approach, whatever that is. It also gives you time to think about what on earth is going on. So everything, even if it's like, aha, I know this is like complete heart block, just go through it anyway. Makes you look slick, makes you look like you know what you're doing, which is what we're trying to achieve. Yeah, and I think just be definitive. It's in certain stations, you need your differential, and that's really important. When you're looking at an ECG, it's likely to be something definitive, or if you're looking at an X-ray, likely to be something definitive. And I failed my acute station because I was like, oh wait, look, no, it looks like a pneumothorax. I'm going to go with pneumothorax. And I was like, no, wait, D-dimer's raised. I think it's a PE. Not a good thing, not a good way to be honest. So if it's data, try and be definitive. You can have this discussion, just have it in your head. And that's data. Data that you may not have looked at to look at would be lung function curves, ECGs, X-rays, and like maybe just look at some orthopedic X-rays like knees and stuff, because those are the things that quite threw me quite a bit. And also they love cord equina, have a little look at like disc herniation and things like that, cord compression. Fine, okay. Clinical skills. Now we've all been to the clinical skills lab and we all know our aseptic, non-touch technique, and we know how to put on gloves. I think putting on gloves is like a big factor in the ISCE, but hopefully with COVID and things, you guys are pretty good with that. If you can't get the gloves on, do not create a big scene. Either try and get them on or just move on and be like, you know, this is not working out for me. I'm just going to carry on without gloves. Wash your hands. I'm sure you'll do this. I think just be confident with the equipment is a big thing. Don't give yourself a sharps injury. Sharps go in the box, in the bin, not on your fingers or hands. Don't rush through this, right? Because you need to be confident and do it well. That's what they want to see. They want to see the process. I think a lot of the ISCE is the process rather than achieving the endpoint. Aseptic technique, use the BNF, talk to the patient, tell them what you're doing because it helps you know what you're doing. And I took bloods from this patient today and I was like, you're doing really well, Mr. So-and-so, but actually I was talking to myself. I was motivating myself that I was doing really well. I think that's it for clinical skills. I think you guys will be fine. It's just time, especially on stations like wound swab. Again, the process, have that trolley, do Sean proud. Okay. And also this is going on YouTube. Otherwise it'd be more bants, but I've trimmed it down. Right, investigations, boxes. I love boxes. You know, Imperial students don't know much about boxes. So it's really useful. Bedside investigations, bloods, cannulation, all the orifices. Now, obviously, you do not need every single one of this in every presenting complaint. Okay, so you need to tailor it, but as long as you follow this process, you'll look very slick because essentially the BOXE are things you can organize as an F1 or even a final year. The special test is when you need to get your senior support. That's when you need to tell the reg, like, look, got this patient, they've fallen, they've hit their head, going to do a CT head. Is there anything else I can do? Senior support is really important in the management part. You need to be able to escalate things well, because even as an FI1, my job is to document and request and refer, but I have that support of my senior. And I think it's something that's often missed in management plans. You go through you go through everything really well, and then it's like, actually, I need to get some help. Double two, if it is literally an arrest situation, if you need more hands, you will need a met call, right? Don't just stand there and be like, right, I'm going to do this, this, this. At some point, you're going to need more help. Acknowledge that, and you won't get any of it, but at least you've realized it. Be succinct. They will quiz you on why you have ordered investigations, like why on earth do you need that? And you'll just be like, I don't know, someone told me to do it. Try and have a reason before you say something. And of course, the acute dynamic environment, so things like analgesia. Bloods, be specific. So you've got all these different kinds of bloods, don't just say bloods. They absolutely hate that. You will not stand out. But, do you need an ABG? Is this like respiratory oxygen requirement thing? Blood cultures, septic, spiking, temps. Specific, like I need full blood count because I need to see the white cell count, user needs because I need to check the renal function. You can almost always say that because you need to start drugs of some sort, similar to LFTs. Also, if they're having a major hemorrhage, you need to potentially get some blood, so cross-match, group and save, and things like clotting as well. Important. You also need to get some access. Sometimes you can say, I'll get some access, I'll get some bloods. That looks good. And don't forget glucose. Glucose is close to my heart. Some of you may know that. Okay, explanation station, right. Use simple terms, no jargon, practice on like your non-medical mum, like I did. Like she's like, what is this? And it's like, that's not even jargon. Right, don't act too well rehearsed. It's still a conversation. It's dynamic. The patient, they're gonna ask you things that you're like saying it from your notes, and they're going to be like, actually, tell me a bit more about this. And you're like, no, actually, I've not prepared it this way. Not how a conversation works. Take into account their questions, take into account their particular concerns, but still base your what you've prepared around that. Find out early if the patient has specific questions. And loads of people, you're going to get a session on this tomorrow, so I won't go on, but also signposting is important to other resources. Okay, finally, presenting, right, big one that everyone's like, oh my God, I can't, do I have to put my hands behind my back, eye contact, what do I say? Yeah, you can put your hands behind your back, that's fine. Good eye contact is good. Look at the examiner, not the patient behind you. Even if they've got something very interesting going on, you look at the examiner. You present the way that you took so for the examination, the way you did the exam. So on inspection, salient points, important positives, and also excluding the negatives, the crucial negatives, like the red flags. And that would be the way to go with presenting back. Keep it short. You don't need to tell them about the PET cap, right? So you can exclude that. It's just the things that are going to get you to your diagnosis, and also the important negatives on why you've ruled out certain fatal conditions. Don't stress too much about presenting, but throughout your examination and your history, just make a mental note of the things that you would like to say at the end. Fine, right. Okay, CBD station, never done this in my life, but on acute take, I always have to clerk patients in, and it's always like presenting a case, because in a CBD station, you are looking at a holistic approach to the patient. So clear, concise history, and what you found on examination, what examinations were performed. The hospital course, essentially what investigations they had, if there was any changes, did they get better really quickly, did they get worse, any new examination findings, things that are changed. Investigations include blood results, imaging, I don't know, lumbar puncture results, anything that's kind of like, this was something interesting that helped us rule in or rule out different differentials. Management, I would split into, right, acute management at the front door. What did they do in A&E? What did you do then on the ward? Ongoing management, and then did they leave? Were they discharged? Outpatient follow-up? What's going to happen next? clinical side. Ethical basically outlined your ethical issue of choice. This could be safeguarding, could be about capacity, could be about DNAR discussions, family discussions, mental health, could be about social support in the community. How did this come about? Like, how did you know that there was a problem with safeguarding? What discussions were had with the patient or the family or your team? Which other teams did you have to involve for this to take place? Did you have an MDT? And then like discussing the scenario and, you know, what resolutions there were or what was put in place for it to either resolve or actually you couldn't help it and you had to escalate it. And that would be, I think, quite a neat way of setting out the CD. Oh my goodness. Okay, right, few last words. You are nearly at the end and you're going to graduate finally. I feel like ISCEs have been part of your life for too long, and you're finally going to get through them. When you become F1s, you are going to be able to look up stuff on your phone, on the ward round. It's going to be so good. So literally in 4 days, that should be like your peak knowledge time. And yes, there will be things that come up in the ISCEs that you've not looked at, and that's why you need to just go back to basics. And you know, it's all about the process, and that's what they want to see. And that's it. I'm going to hand you over now to Rashira, who is a better pro than I am. Thanks.
No, don't say that. Thank you very much for the introduction, Angelica. I thought your slides were really funny, to be honest. Like the one where you say like CBA and then you slash and then say CBD instead.
It would have been more top bands if it wasn't going on YouTube. So yeah, if you want more bands, you can slide into my DMs as well if you want more help.
Okay, all right. Hi, everyone. My name is Ruchira. I'm currently an academic foundation 2 doctor in Princess of Wales. Some of you may not know me because I graduated about how many years? 2-3 years ago. How do I move on? Oh wait, Angelica, you're controlling the slides.
Oh, I'm sorry. Okay.
Yeah. Okay, so who am I? I'm currently an AFP doctor at Obs and Gynae. I'm also doing a postgrad in medical education. And I feel like I need to mention that I'm also a COVID survivor. I think that's one of those things that you need to identify nowadays. It's like having HIV, but yeah, COVID instead. Okay, next. Okay, so why is it important to have good communication skills? Basically, it plays a huge role in clinical practice, doesn't it? And patients always remember what you say, and you want to avoid any misunderstandings and misinformation as well. You don't want to get sued on your first day of being an F1. And yeah, it reflects on you as a clinician and you as a person as well. Angelica, next slide, please. Okay, I found this quote on Google, which I thought was very insightful. It says, "Be careful what you say. You can say something hurtful in 10 seconds, but 10 years later, the wounds are still there." So very, very true. Not only the things that you say, but the things that you don't say as well actually makes a difference. Angelica, next slide. Yeah, so like what I mentioned earlier, you're also responsible for what you say and what you do not say. And this was also by a quote by someone else, Martin Luther. Angelica, next. Okay. Oh yeah. So what is nonverbal communication? So basically, it comprises of 6 different components: eye contact, tone of voice, your mannerism, whether are you approachable towards the patient, your posture, and your facial expressions as well. Angelica. Yeah. So with hand gestures, just to be mindful of how you're placing your hands. You don't want to fold your arms in front of the patient when you're talking to them. And just simple things really. And sometimes I know when you're in a very stressful position, like for example, in your exams, you tend to forget about simple things such as your body language. So this slide is just to show you some different ways of how you can place your hands when you're speaking to patients as well, or breaking bad news. Angelica. Yeah. And yeah, with facial expressions, especially now when everyone is wearing a mask when they speak to patients, or even when the patient the patient that you're talking to may also be wearing a mask. And I guess it's an ongoing challenge nowadays to be able to read the patient's facial expressions, and at the same time for the patient to also tell what your facial expression is. So we'll definitely recommend standing in front of a mirror and just, practicing your different facial expressions and emotions and exercise all those facial muscles as well. Angelica. Oh, and yeah, the most important is to make sure that you avoid 100% resting beach face. Sorry, you may need to censor me when I say the B word, but yeah, I think some of us do have RBF, and it is very important to be aware when we are showing it, because sometimes patients may think that you are coming across as non-approachable, or they may not feel as comfortable asking you questions. So something to just be aware of as well. And eye contact, very, very important. I thought this diagram summarizes eye contact. So always make sure that you're sitting right in front of the patient and with squared shoulders, hands placed on your lap, or if you're nervous, you can hold your hands together, and make sure that you're having direct eye contact with the patient whenever you're breaking bad news or taking a history or explaining a condition or treatment as well. And yeah, this is just a diagram just to show different postures and just to be aware of how you are appearing when you're speaking to patients or when taking a history as well. And yeah, so this is just a slide just to show nonverbal communication presented by the patients to you. And, just play off what the patient or the actor or actress is showing, and to have a certain level of self-awareness as well when you're taking a history from the patient. Yeah, I think that's pretty much my section. Is very, very short in comparison to Angelica's. But I hope we haven't put you off taking the exams. Yeah, we're happy to answer any questions that you may have in the chat, or feel free to unmute your mics as well.
Yeah, we'd be really grateful for some feedback. But otherwise, it was an absolute honour to do this pro bono as well. So thank you, and massive good luck as well. I'm just going to go onto the chat. So if you've got any questions, let me know, or you can always email us or whatever.
Thank you very much, Angelica and Ruchira, for the very informative talk. We'll make sure we won't, show to patients your real scared face or your resting B hashtag face. So guys, if you have any more questions, you can either save them for the final day or you can ask them now. In terms of the CBD station, we feel that since it's a new station and you get time to prepare it yourself, you actually are at a very good advantage, because you're able to prepare everything. You know what's exactly happened to the patients. So you're just basically rationalizing everything that has already happened. Okay, there is a very short feedback form, as we have put in the last few days. It only consists of 2 questions. So if you guys want to help us to improve these sessions, if you feel like these sessions are useful, not useful, what can we do to make it better, please let us know. Can you send the feedback form again? The feedback form is on the screen. It's still shared on the screen. It's a QR code on the right. So for tomorrow, we have 2 of our very famous, as I would say, junior doctors who are also Cardiff grads, who will be talking about how you would ace specialty stations and explanation stations as well. As you guys probably know, the layout of the ISCE is now not as specific as you have a specialty day, but you have quite a lot of mix in between. Yeah, stay tuned for tomorrow. The link will be up.